Good afternoon to all. I'm presenting a paper on the topic sST-2 biomarker as an indicator of severity of heart failure in children with acute myocarditis. Myself, Dr. Arushi Rastogi, a resident of Department of Pediatrics at RML Hospital, New Delhi. As we all know, myocarditis is still a challenge to diagnose and treat. Endomyocardial biopsy, even though considered to be gold standard for the diagnosis of myocarditis, is seldom done owing to its invasiveness and low sensitivity. With the upcoming CMR, the diagnostic accuracy has improved, and even though it is widely available, sufficient pediatric data is lacking, and hence recommended only in clinically stable children with suspected myocarditis. BNP has proven to be a very good biomarker in adults and has been used to support the diagnosis and exclude heart failure in adults, used as a chronic heart failure marker for its stratification and used as a prognostic marker in hospitalized children. But there is paucity of pediatric data, and there is high intra-individual variability owing to differences in age, weight changes, and hence BNP is only used as an adjunct to aid in the diagnosis and monitoring of children with heart failure. ST2, a background. ST2 stands for suppressor of tumorigenicity 2. It is an interleukin 1 receptor family member. Interleukin 33, which is expressed by fibroblasts, smooth muscles, and epithelial cells, are released in response to stress. ST2 exists in two isoforms. One is a transmembrane or the ligand form, and one is a soluble or the circulating form. The IL-33 binds to the transmembrane ligand form and exerts a cardioprotective action. The soluble form of ST2 acts as a decoy receptor by binding to the circulating IL-33 and blocks its cardioprotective action. In this diagram, we can see that IL-33 is a circulating interleukin which is released in response to stress. It binds to this ST2 ligand form and exerts the cardioprotective action by altering the gene expression. The soluble ST2, which is circulating a form of this biomarker, binds to the IL-33 and inhibits its binding to ST2 ligand and hence promotes fibrosis, hypertrophy, and apoptosis of the cardiac myocytes. The primary objective of my study was to correlate the levels of the cardiac biomarker with the clinical scoring of heart failure severity in children with acute myocarditis using the modified Ross score as the severity of heart failure. Secondary objective was to correlate these levels with the short-term outcome at 3 months. The inclusion criteria for the above study was all children aged from birth to 14 years, fulfilling the diagnostic criteria for acute myocarditis with the onset of symptoms for less than 3 months duration. The outcome measures at discharge in 3 months was correlation with the severity of heart failure using the modified Ross score, number of free hospitalizations after discharge, and mortality. Results. sST2 levels was found to be significantly higher in cases. I had a group of 20 patients. We did a case control where I used healthy age sex matched controls, and sST2 levels were significantly higher in case group. The sST2 levels were then also at admission were compared with the heart failure severity depending upon the modified Ross score at admission. And we can see that they were significantly higher in the moderate to severe group. Comparing the outcome at 3 months, sST2 levels were lower at admission in the group which had survival and had no readmission. It was found to be significantly higher in patients who had survival and had readmission during the outcome and in that 3 months, and in patient who had mortality either during the hospital stay or at discharge. The patients who expired, who had mortality within the hospital stay or after discharge, had significantly ST2 levels at admission compared with the good outcome at admission and discharge. In our results, sST2 levels are found to be higher in cases when compared to compared with healthy age and sex match controls. Rahim et al. Also found a significantly higher levels of sST2 in children with heart failure compared with controls, and Martinez et al. Depicted that elevated sST2 in children with LV dysfunction compared with the control group. Secondly, SST2 levels at admission very well correlated with the modified Ross score, which is a clinical score, and had increasing levels with increasing severity of heart failure. Rahim et al. Also found that the SST2 levels that were significantly higher in Ross class 4 compared with Ross class 3 and 2, and Elaziat et al. Found that higher SST2 levels were increasing with severity of heart failure. This suggests that SST2 has a good role in predicting the and evaluating the clinical severity of heart failure. There was significant association between the SST2 at admission and outcome at 3 months. Mueller et al. Found strong independent association of SST2 levels at presentation with an all cause mortality at 1 year. Yu et al. Found patients that with a higher baseline SST2 levels had a higher risk of adverse events at 6 months and at long term follow up versus the patient with lower baseline SST2 levels. Reban et al. Found that elevated SST2 levels to be associated with a twofold increase in mortality, regardless of other parameters, including the natriuretic peptide. This also highlights the ability of SST2 to predict poor outcome as well as prognostication regarding the children with acute myocarditis. Future directions for this biomarker, we could do this a similar study for a larger sample size to observe the variation in children in the pediatric population. We can have a serial SST2 estimation, which would give a better insight as to control of the heart failure, and a long term follow up and monitoring the outcome and disease progression using this biomarker could be done. Thank you.